Hello, good morning to all of you. Today's topic will be Myofunctional Appliances Part 2. You've already been explained part of the topics in Part 1 and today we will continue more in Part 2 lecture. These are the learning outcome. By the end of the lecture, you should be able to define and describe the principle of functional appliances. You should be able to classify functional appliances and you should be able to explain the mode of action of functional appliances such as activator, Bionator, twin block, Frankel, Jasper jumper and Herbst appliances. So in part 1, you're already being explain how to define and describe the principle of functional appliance and you already being explained how to classify the functional appliances. So in this part 2 lecture, we will focus more on the mode of action of functional appliances. So what is the mode of action of various myofunctional appliances? This is what we call the causal chain. So what happened is the functional appliances will increase the contractile activity of lateral pterygoid muscles, and then this activity will cause intensification of the repetitive activity of the retrodistal pad. What happens next is increase in growth stimulating factor. It will cause enhancement of the local mediator and reduction in local regulators. There will be also change in condylar trabeculae orientation, which will cause additional growth of condylar cartilage and additional subperiosteal ossification. And this will produce supplementary lengthening of the mandible. So now, this is the list of myofunctional appliances. In part 1, you're already being explained about the vestibular screen, lip bumper and activator. So in part 2, we will be continue discussing about function regulator of Frankel appliances, followed by Bionator, then twin block, Herbst appliance and lastly Jasper jumper. Function regulator is developed by Professor Rolf Frankel in Germany. This appliance is also called Frankel appliance, function regulator, function corrector, vestibular appliance, and oral gymnastic appliance. The Frankel appliance has two main treatment effects. First, it serves as a template against which the craniofacial muscle function. The framework of the appliance provides an artificial balancing of the environment, thereby promoting more normal pattern of muscle activity. Secondly, the appliance removes the muscle force in the labial and buccal area that restricts skeletal growth, thereby providing an environment which enables skeletal growth. The next one is the Frankel philosophy. Frankel has based his appliances on the following principle. The first one is the vestibular arena of operation. Secondly, the sagittal correction via tooth-borne maxillary anchorage. Thirdly, the differential eruption guidance. Fourthly, the minimal maxillary basal effect. And lastly, the periosteal pull by buccal shield or lip pads. I will explain one by one. Firstly, the vestibular arena of operation. According to Frankel, the dentition is influenced by perioral muscle function. Abnormal perioral muscle function creates a barrier for the optimal growth of the dentoalveolar complex. Thus, the Frankel appliance is designed to hold away the muscle from buccal and labial away from the dentition so that the dentoalveolar structures are free to develop. In addition, the Frankel appliance acts as an exercise device or an oral gymnastic device that aids in correction of the abnormal perioral muscle function. Okay, secondly, the sagittal correction via tooth-borne maxillary anchorage. The Frankel appliance is anchored firmly in the maxillary arch by means of groove in the molar and canine regions. The mandible is positioned anteriorly by means of an acrylic pad that contacts the alveolar bone behind the lower anterior segment. This lower lingual pad acts more as an proprioceptive trigger for postural maintenance of the mandible. And then the differential eruption guidance. So what will the Frankel appliance do? The Frankel appliance is free of the mandibular teeth. This allows selective eruption of the lower posterior teeth that aids in correction of the discrepancy in the vertical dimension and also helps in sagittal correction of the class 2 malocclusion by allowing upward and forward movement of only the mandibular teeth. Then, for the minimal maxillary basal effect, it has been noted that in most class 2 malocclusion, the maxillary position is close to normal while the mandible is retruded. The Frankel appliance has relatively little retrusive sagittal effect on the maxilla in contrast to the marked protrusive change in mandible. And lastly, the periosteal pull by buccal shield and lip pads. The buccal shield and lip pads are extended to bring about outward periosteal pull. This will aid in bone formation at the apical base. So what is the mode of action of Frankel appliance? The following are the effects of the Frankel appliance on the dental-alveolar structures. First, it will increase in transverse and sagittal intraoral space. Secondly, it will increase in vertical space. Thirdly, mandibular protraction. And finally, the muscle function adaptation. Frankel also has recommended certain oral exercise that called oral gymnastic. So some of the exercise recommended are to keep the lip closed at all time. This can be aided by asking the patient to keep a piece of paper between the lips. Then swallowing, speaking, and so forth become more or less an exercise when the appliance is used. Okay, now for types of functional regulators or FR. There are 5 types of FR, which is FR1, 2, 3, 4 and 5. For FR1, they are used for treatment of class 1 and class 2 division 1 malocclusion. The FR1 is divided into 3 following types, which is FR1A, which are used for class 1 malocclusion where there is minor to moderate crowding. It is also used for class 1 deep bite cases. For FR1B, it is used for class 2 division 1 malocclusion where the overjet does not exceed 5 mm. For FR1C is used for class 2 division 1 malocclusion in which the overjet is more than 7 mm. For FR2, they are used for treatment of class 2 division 1 and division 2. For FR3, they are used for treatment of class 3. FR4, they are used for treatment of open bite and bimaxillary protrusion. FR5, they are functional regulators that incorporate headgear. They are indicated in long face patients with a high mandibular plane angle and vertical maxillary access. The FR2 of Frankel is the most commonly used appliance and will therefore be discussed in detail. Okay, now we will focus on FR2 of Frankel, which is most commonly used appliance. They are used for treatment of class 2 division 1 and class 2 division 2 malocclusion. The FR2 consists of acrylic and wire components. So for the acrylic components include buccal shield, lip pad, and lower lingual pads, whereas for wire components is include palatal bow, labial bow, canine extension, upper lingual wire, lingual crossover wire, support wire for lip pads, and lower lingual spring. I will show you photos that will explain these two basic components of the FR2. This is a figure showing the FR2. Uh, we will focus first on the acrylic component. The first one is buccal shield. Buccal shield is labeled as F and is situated at the buccal area that covers between the cheek and the teeth. And then secondly, look at G. G is the lip pads. And then finally, look at I. When you look at eye is situated at the lingual area, and this is called lower lingual pad. This is to separate an area between tongue and the lower dentition. And that is the acrylic component. There is only three acrylic component, which is buccal shield, lip pads, and lower lingual pads. And then secondly is the wire component. The wire component, the first one is A, labeled bow, which is the wire that extends from the buccal shield and then bend downward and lies on top of the incisor edge of the upper incisor. And then secondly is the canine loop. Canine loop extends from the buccal shield and then touching the canine labial area. When we see in this figure, canine loop is labeled as B, and then C is the upper lingual wire. Okay, so it's situated on the lingual area. And then look at D. D is the lingual crossover wire. This is also situated at the lingual area. And then E. E is the support wire for lip pad, which is connected from the buccal shield to the lip pad. And then H, situated at the palatal area. H is the very simple, is the palatal bow. And then finally it's I. I situated at the lingual part of the lower incisor. This is called lower lingual springs. Okay, we already finished about FR2. Now we will move into FR1. So as I explained before, there are three modifications of FR1, which is FR1A, B, and C. FR1A is used for class 1 crowding and deep bite cases. FR1B is used for class 2 division 1 malocclusion with overjet less than 5 mm, and FR1C are used in class 2 division 1 malocclusion with overjet more than 7 mm. Now, what is the component of FR1A of Frankel? There are two components, acrylic and wire. And then for the acrylic components, they have two vestibular shields and they have two lip pads. So they don't have a lingual pads as FR2. Okay, and then for the wire components, they have palatal bow, labial support wire, lingual bow, and canine loops. So the wire and the acrylic components of FR1A is less than FR2 of Frankel. For FR1B, as usual, all Frankel have two components, acrylic components and wire components. So the difference between FR1B and FR1A is FR1B have two additional wires. They have two additional components compared to FR1A, which is they have extra lingual acrylic pads and they also have lower lingual springs. For FR1C of Frankel's, the buccal shields are split horizontally and vertically into two parts. The antero-inferior portion contains the wires for the lingual acrylic pads and lip pads. This permits the forward movement of the acrylic section of the appliance. The space created is filled with self-cure acrylic. FR1C is used when the multiple stage advancement is needed. Now we will move into FR3 of Frankel. FR3 is indicated in cases with class 3 malocclusion due to maxillary retrusion and not mandibular prognatism. It should be used during deciduous, mixed, and permanent dentition. FR3 has two upper lip pads. The purpose is to eliminate the restrictive pressure of the upper lip on the underdeveloped maxilla, to exert tension on the tissue and periostal attachment in the depth of maxillary sulcus to stimulate bone growth, and to transmit the upper lip force to the mandibular through the lower labial arch for a retrusive stimulus. Some of the forces are also transmitted via the vestibular shield. The buccal shields stand away from the maxillary posterior dentoalveolar structures by about 3 mm. The buccal shields are in contact with the mandibular apical bone. They serve to eliminate the buccinator muscle force and also cause a periosteal pull leading to bone growth. Labial support wire connects the lip pads together and to the buccal shield. The labial bow is placed in the lower arch. Protrusion bow is seen behind the upper incisors to stimulate forward growth of these teeth. The palatal bow lies slightly away from the mucosa to prevent irritation. It crosses the palate behind the last erupted molar. Functional regulator 4 of Frankel is used in mid-dentinal stage for correction of open bite and bimaxillary protrusion. The FR4 has the same vestibular configuration as FR1 and FR2. It lacks canine loop and protrusion bow. It consists of 4 occlusal rests on the maxillary first molars and first deciduous molars to prevent tipping of the appliance. The palatal bow is similar to FRT, which is placed distal to the last molar. Functional regulator 5 of Frankel. There are functional regulators that incorporate headgear. They are indicated in patients with long face syndrome having a high mandibular plane angle and vertical maxillary access. The appliance consists of posterior acrylic bite blocks that prevent molar eruption due to the action of elevator muscles of the mandible. Headgear tubes are incorporated that are used for extraoral traction. Management of FR. The wear time are as follows. We can ask the patient to wear the functional regulators 2 to 4 hours per day for the first few weeks. After 3 weeks, we can ask the patient to wear the FR for about 4 to 6 hours per day. And after third visits, which is around 2 months, we can ask the patient to start wearing the FR full time. The patient is also asked to perform the oral gymnastic, for example, talking, reading, and tightly grasping the appliance in the vestibule. Okay, the next type of myofunctional appliance is Bionator. Bionator was developed by Bolters during the early 1950s. Bionator is quite similar to Activator. I've already explained about Activator in the part 1 lecture. However, Bionator is better than Activator because Bionator is less bulky and more elastic. There are 3 types of Bionator, which is the standard Bionator, the class 3 appliance, and the open bite appliance. This figure shows standard appliance. Standard appliance is used for the treatment of class 2 division 1 and class 1 malocclusion having narrow dental arches. The standard appliance consists of relatively slender acrylic body fitted to the lingual aspect of the mandibular arch and part of the maxillary arch. The acrylic extends up to the distal of the first permanent molars. The maxillary plate covers only the molars and the premolars, with the anterior region remaining uncovered. The acrylic extends 2 mm below the gingival margin. The interocclusal space of some of the buccal teeth is filled with acrylic extending over half of the occlusal surface of the teeth to stabilize the appliance. The standard appliance consists of 2 wire components, which is the palatal arch and vestibular wire. The palatal arch is made of 1.2 mm diameter wire. It emerges opposite the middle of the first premolar and follows the contour of the palate, forming a curve that reaches the distal surface of the first permanent molar. The palatal arch is kept 1 mm away from the mucosa to prevent irritation. The vestibular wire is made up of 0.9 mm stainless steel wire. It emerges from the acrylic below the contact point between the upper canines and premolar. It rises vertically and is bent at the right angle to go distally along the middle of the upper premolar crowns. Mesial to the molar, a rounded bend is made so that the wire runs at the level of the lower papilla up to the mandibular canine where it is bent to reach the upper canines. It forms a mirror image on the opposite side. The vestibular wire is kept away from the surface of the incisor by the thickness of a sheet of paper. The lateral portion of the wire are sufficiently away from the teeth to allow expansion of the arch. This is the second type of Bionator. Class 3 appliance is used in mandibular prognatism. The acrylic parts are similar to the standard appliance. The palatal arch is placed in the opposite direction so that the rounded arch is placed anteriorly. The vestibular wire runs over the lower incisor instead of terminating at the lower canines. The third type of Bionator is the open bite appliance. This is used in open bite cases. The palatal arch and the vestibular wires are same as the standard appliance. The maxillary acrylic portion is modified so that even the anterior area is covered. Its purpose is to prevent the tongue from thrusting between the teeth, as the tongue is responsible in most cases of the open bite. Indication of Bionator. So Bionator is used in the Class 2 Division 1 cases with well-aligned dental arches, retruded mandible, no obvious skeletal discrepancy and labial tipping of the upper incisors. Bionator also can be used in Class 3 cases, Class 3 malocclusion and open bite cases. The next type of myofunctional appliance is the twin block. Uh, Generally in Malaysia, in a class 2 division 1 myocclusion, most clinicians will use twin block in the treatment of the patient in the mixed dentition and a growing patient. So what is twin block? Twin block combines inclined planes with intermaxillary and extraoral traction. The appliance consists of an upper and a lower plate having occlusally inclined bite plane that induce favorably directed occlusal force by causing a functional mandibular displacement. So how to design the twin block? The twin block consists of upper plate and the lower plate. These two plates must be used together so that they can produce a definitive action. So that's why we call it twin, because it will only affect on the dentition when they use together. So what we have in the upper plate? Upper plate is retained by modified Adam clamps. There is a tube for face bow can be incorporated to the clamps. In the upper plates, we can also add jet screw for maxillary expansion. And the bite block covers the lingual cups of the upper buccal teeth extending anteriorly till the mesial ridge of the upper second premolar. So for the lower plate is retained by ball-ended clamps anteriorly. The bite blocks extends distally up to distal marginal ridge of the second premolar. The lower molars are kept free to allow eruption. However, in this figure 15, you can see there is Adam clamps on the lower molar. So some clinicians, they won't put the Adam clamps for retention. They only put ball-ended clamps at the lower incisor and Adam's clamps on the premolar because they want to allow the molar to freely erupt. And then the upper and lower block bite interlocks at 45-degree angle. So when the upper plates and the lower plates of the twin block are used together, the patient need to move the mandible forward so that the inclined plane will engage together and then the mandible will posture anteriorly. The mandible will posture anteriorly. How do the twin block works? Now we will look into the mode of action of the twin block. The twin block works on the philosophy of occlusal inclined planes and use of masticatory muscle forces throughout the day. If the mandibular inclined planes are in a distal relation to that of maxilla, then the force acting on the mandibular teeth will have a distal force vector leading to a class 2 growth tendency. How to do bite registration for twin block? The bite registration for twin block is similar to all myofunctional appliances. The mandible is sagittally advanced by 5 to 7 mm according to the overjet, or till the upper and lower incisor are in edge to edge bite. In a patient with overjet is too much, which is more than 7 mm, the stepwise advancement is preferred. Vertically, the bite is opened by 3 to 5 mm. Okay, some of you may wonder what is the stepwise advancement. For example, in cases with patient with overjet of 14 mm, so the maximum patient can protrude the mandible forward is around 7 mm only. So first set of twin block is done with a bite registration of 7 mm. So patient will wear the twin block for about 3 to 4 months, and then after that we will do stepwise advancement after patient wearing the twin block around 3 to 4 months. And then this stepwise advancement is done by asking the patient to move the mandible forward to get another 7 mm advancement, so that then only we will get upper and lower incisor in edge to edge bite. Okay, because initially patient have 14 mm overjet and he or she cannot protrude until 14 mm, but he or she can only protrude to 7 mm. So they need to advance twice. In cases with severe skeletal discrepancy, extraoral traction is used. The twin block appliance uses a Concord face bow that combines the extraoral traction with intermaxillary traction. The face bow is unique as it has a curved labial hook. The face bow is attached to the maxillary molar. Intermaxillary elastic can be used from the curved labial hook to the face bow to the mandible. Extraoral traction of 200 grams each side for 8 to 10 hours a day is prescribed. Intermaxillary force of 150 grams is applied from the lower appliance to the labial hook of the Concord face bow using elastic. This photo shows that the patient is wearing twin block intraorally and is being attached with the Concord face bow as an extraoral traction. How to connect the Concord face bow to the twin block? The Concord face bow is being connected through the upper maxillary molar. On the upper plate of the twin block, there is a Adam's clasp at the upper maxillary molar. So a buccal tube is being, a headgear tube is being attached to the bridge of the Adam's clasp of the maxillary molar, where the Concord face bow is being connected to the upper plate of the twin block by attaching through this headgear tube. And then another additional part of the Concord face bow is there is a curved hook at the labial part of the face bow, where in this hook we will attach a intermaxillary elastic from the hook to the ball ended clasp of the lower plate of the twin block to give a intermaxillary elastic. For the Concord face bow, it will be being attached to the headgear to give the extraoral traction and force. The next one is the fixed twin block. The twin block appliance may be designed for direct fixation to the teeth by bonding. It resembles a Herbst appliance and substituting occlusal inclined plane for telescopic tubes to guide the mandible into protrusive position. I will be explain more about Herbst appliance in the next two slides. In reality, twin block is the most commonly used functional appliance in the government dental clinic nowadays in Malaysia. This is because this appliance has a good patient acceptance due to the following reasons. The bite plane offers greater freedom of movement in anterior and lateral excursion other than other functional appliance, so patients feel comfortable wearing twin block. compared to the other types of functional appliance. This will enhance patient compliance. Less interference with normal function and its significant changes in patient appearance are seen in 2 to 3 months. Another type of myofunctional appliance is the Herbst appliance. Herbst is a fixed functional appliance that was developed by Emil Herbst in the early 1900. It was introduced to the dental profession at the International Dental Congress in Berlin in 1905. This appliance was soon forgotten and was reintroduced in 1979 by Hans Penches, who popularized its use. Indication for use of Herbst appliance. The Herbst appliance is indicated in correction of class 2 malocclusion due to retrognatic mandible. They can be used as an anterior repositioning spleen in patients having temporomandibular joint disorder. The following are the specific indication of the Herbst appliance. Firstly, in the post-adolescent patient, treatment with herbs may be completed within 6 to 8 months. Thus, it is possible to use the residual growth left in this patient. So, patient must be still growing, so it's suitable for this type of treatment. Secondly, for mouth breathers, herbs appliance can be used in mouth breathers unlike other removable functional appliance. And finally, in uncooperative patient, this is a fixed appliance and it is being cemented in the mouth and is worn 24 hours a day. Thus, it can be used in uncooperative patients. So now we want to look into the design of the Herbst appliance. The posterior maxilla and mandibular teeth were fitted with band or acrylic spleen. Then, both upper and lower spleens were connected using a bilateral telescopic arm that keeps the mandible forwards. The device consists of a tube to which a plunger fits. The tube is fitted to the distal end of the maxillary molar, while the plunger, resembles a rod, is fixed to the lower first premolar. This photo, which is labeled A, B, C, and D, shows the Herbst appliance in a different view. Picture A shows the side view of the Herbst appliance. We can see that there is a plunger which is in the dark grey color and the tube in the light grey color. The plunger, which looks like a rod, will slide in and out of the tube. Picture B shows more detail about the plunger and the tube. The tube is in the light grey and the plunger in the dark grey. Picture C shows the maxillary view of the Herbst appliance. There is a palatal bow that holds the right and left side of the Herbst appliance. Picture D shows the mandibular view of the Herbst appliance. There is a lingual bar that connects the left and right side of the Herbst appliance. There are two types of Herbst appliance. The first one is banded Herbst and the second one is bonded Herbst. For banded Herbst, the upper and lower first premolar and first molars are banded. The tubes are fixed to pivot soldered to the distobuccal aspect of the upper first molar band. The shaft or rods or plunger are fixed to pivot soldered to the lower first premolar band. For the bonded Herbst, it is a wire reinforced acrylic spleen that covers the occlusal and parts of the buccal and lingual surface of all teeth except the anteriors. The pivots are fixed to the wire framework at the distal buccal aspect of the upper first molar and the mesial part of the lower first premolar. The tube is fitted onto the pivot in the maxillary molar area, while the shaft or plunger is fixed to pivot in the mandibular premolar region. Treatment effect. The following effects are seen when the Herbst appliance is used for the treatment of class 2 malocclusion. Firstly, class 1 molar relation or overcorrected class 1 molar relation is seen after the treatment. There will be an increase in mandibular growth. Thirdly, A certain amount of distal driving of the maxillary molar that helps in the correction of the molar relation, overjet reduction by increase in mandibular length and proclination of the mandibular incisor, and inhibitory influence on the sagittal maxillary growth. Westlander suggests double contour of glenoid fossa indicating anterior transformation of the glenoid fossa, and increase is SNB angle and decrease is SNA angle. These photos summarize the intraoral and extraoral treatment effect of Herbst appliance. For the extraoral effect, we can see that in the picture before treatment, patient has a convex profile, and then after treatment, patient has a straight profile. It shows that there is an increase in the mandibular growth. For the intraoral photo, we can see that after treatment, patient has a class 1 molar relation, and also patient has a good class 1 occlusion after the Herbst appliance treatment. The following are advantages of Herbst appliance. The action is continuous because it is a fixed functional appliance and is being cemented to the teeth. The treatment duration is short due to the continuous nature of action. Less patient cooperation is needed. Can be used successfully in patients who are at the end of growth phase, and can be used in patients who have mouth breathing habit due to nasal airway obstruction. The disadvantages of Herbst appliance are as follows. It may cause discomfort to patient. There will be minor functional disturbance in the masticatory system, increased risk in the development of dual bite, repeated breakage and loosening of the appliance, plaque accumulation and enamel decalcification, tendency for posterior open bite. This is the final type of the myofunctional appliance in this part 2 lecture, the Jasper jumper. This Jasper jumper is a new type of flexible fixed tooth-borne functional appliance that was introduced by J.J. Jasper in the year 1980. Its actions are similar to Herbst appliance but lack of rigidity. The appliance design. The appliance uses a modular system commonly known as Jasper jumper, which can be attached to fixed appliances that are placed on the upper and lower arches. This Jasper module is analogous to the tube and plunger of Herbst appliance, but is more flexible. The Jasper jumper is constructed of stainless steel coil that is attached at both the end to stainless steel end caps. The modules is given an opaque polyurethane covering for purpose of hygiene and comfort. The Jasper module are available in 7 sizes ranging from 26 mm to 38 mm in length. The end caps are attached to the fixed appliance at the maxillary posterior and mandibular anterior region. The fourth module is attached posteriorly to the maxillary arch by a ball pin that passes through the facebone tube of the maxillary first molar. Anteriorly, the module is anchored to the lower arch wire distal to the mandibular canine by a small Bionator band and a Latson bead. Since the fourth module is attached to previously placed fixed appliance, care should be taken to have adequately thick arch wire. Indication for Jasper jumper. They are basically indicated for skeletal class 2 myocclusion with maxillary access and mandibular deficiency. For the mechanism of action of Jasper jumper, the force module is selected by measuring the distance between the mesial aspect of the upper facebone tube and the distal aspect of the Latson bead distal to the mandibular canine. To this length, 12 mm is added to get the required length of the force module. Thus, when the teeth in occlusion, the force module tends to curve and producing mesial force on the mandibular arch and distal force on the maxillary arch. The effects of Jasper jumper. According to ranking Parker and Blackwood, the Jasper jumper brings about both skeletal and dentoalveolar changes in the ratio of 40 to 60. For the scatter effect, it holds and displaces the maxilla distally, a small shift of point A distally, clockwise rotation of mandible, and condyle moves forward. The dental changes of Jasper jumper are posterior tipping and intrusion of upper molar, backward tipping of maxillary incisor, and intrusion of mandibular incisor. Jasper states that class 2 correction is brought about by 20% of maxillary skeletal restraining, 20% of backward dentoalveolar movement of maxilla, 20% of forward dentoalveolar movement of mandible, 20% of condylar stimulation, and 20% of downward and forward remodeling of glenoid fossa. The advantages of Jasper jumper are as follows. It produces continuous force, does not require patient compliance by way of timely wear, allows greater degree of mandibular freedom than Herbst appliance, oral hygiene is easier to maintain. Okay, as for now, we finish learning about 5 myofunctional appliance from Frankel Appliance, Bionator, Twin Block, Herbst Appliance, and Jasper Jumper. So we finish part 1 and part 2 myofunctional appliance lecture. So I hope you can already being able to define and describe the principle of each functional appliance. You should be able to classify the functional appliance and you should explain the mode of action of each functional appliance. Okay, for now, thank you so much for your attention. I hope you have a great day ahead and I will be posted some quizzes about this topic later in the Google Classroom. Okay, thank you so much.